Hello, everyone. My name is Irene Gabriel. I'm a professor of medicine here at Dana-Farber Cancer Institute, and I'm excited to share with you some of the work we're doing in early detection and early interception of multiple myeloma. I think the first thing we want to think of is when someone is diagnosed with multiple myeloma, it's because they went to their doctor because they had bone pain or back pain, or they had a fracture or anemia. And in some cases, we're lucky enough to diagnose it early by an early monoclonal protein detected by your primary care doctor or a neurologist. And what we want to do is we want to change that idea of being diagnosed by luck. We want to say that indeed, when I'm diagnosed early, can I see my doctor early and potentially prevent myeloma from happening, preventing the end organ damage, meaning preventing the fractures or kidney failure or anemia, and treating myeloma before it even happens. So how do we do that? Now, we're lucky enough to know that every single case of multiple myeloma diagnosed to date, so if you have myeloma, you must have had an earlier precursor condition, something called MGUS, monoclonal gammopathy of undetermined significance, or smoldering myeloma, the stage before that. And because it's asymptomatic and because we don't screen for it, you may have not been diagnosed with it. But what we want to change is exactly that, is screening for it to find it early so that we can prevent myeloma from happening. Now, you might say that MGUS is actually a very common disease, but it doesn't always progress to multiple myeloma. In fact, if I take everyone walking down the street today over the age of 50, I'll find 3 to 5% of the population having MGUS. Very common. Many of us are walking around with it. In fact, double that size or double that number if you are of African descent or African American, or if you have a first-degree family member with myeloma or any other B-cell malignancy, meaning if your sister or brother have lymphoma or myeloma, you are at a higher risk of developing MGUS also, and we still don't know why. If you have more than 10% cancer cells in your bone marrow, you have something called smoldering multiple myeloma. That means that you're almost ready to go in myeloma. It's almost on fire, it's smoldering. And that means that it has now a 10% chance per year to progress to overt myeloma. And in some patients, it's called high risk smoldering myeloma, meaning high enough that it's 50% chance in 2 years. Now that's dangerous because we know that in 2 years, you have a 50% chance of going on to having fractures or anemia or other lesions. So we want to indeed see those patients early and potentially treat them early before they develop the disease. Now, I just told you that multiple myeloma is more common in Black Americans, and we still don't know why. We don't understand the cause of that, as well as the cause of why you are at risk if you have a family member with blood cancer, or why are you at risk if you've been exposed insecticides, pesticides, post 9/11 exposure. So many of us, Agent Orange, we want to understand what increases that risk so that we can prevent it in the future. So the whole idea that we're doing both in the clinic and in the lab is to diagnose early. Think about breast cancer, we do mammography, we do screening. Yet in myeloma, we don't do screening, although it's a simple blood test. And I can tell you a blood test is much easier to do than colonoscopy or mammography, which are the cancer screening tests that we have. And when we diagnose you with MGUS and smoldering myeloma, the current way we think is watch and wait. Wait until you have organ damage, wait until you have fractures. Yet you never hear us telling a woman with breast cancer who has a stage 1 or stage 2 breast cancer, wait until you have metastasis and then I treat you. So we want to change that way of thinking. We want to treat you early because there's nothing good about waiting for the disease to keep growing in your body. So we divide our work into 3 areas: screening early. And how can we do that? Risk stratification, meaning if you have MGUS, it doesn't mean you will go on to develop myeloma. In fact, 99% chance you will not. So who is really going to develop myeloma, and should we treat them early? And who is not? And we should tell them, go ahead, live your life, have fun. We don't have to worry about that. And we need to stratify those. And we do a lot of that work to give you information more than just your M spike and your light chain. And then early interception, and I mean interception, not prevention, because we are treating patients with smoldering myeloma, potentially even with MGUS in the near future, to truly prevent myeloma from happening. So the first thing is how to screen. And this is the PROMISE study. The PROMISE study, as you can see here online, promisestudy.org. You can also look at the QR code. And if you have myeloma or lymphoma, or if you have MGUS or smoldering myeloma, your brothers, your sister, your mom, dad, and kids are potentially at risk also, because we may be inheriting something that increases our risk. If you are Black American, please consider signing up to this, because it's important to screen for it. If we find it early, just like we do for other cancer screening, we can prevent myeloma from happening. We can change the history of myeloma. So the idea of the PROMISE study is that we screen 30,000 individuals. We expect 10% of them to be positive, because we expect the number to be double or triple the number of people who already have, in general, MGUS at age 50. And we are following those patients prospectively to look at what kind of cancer cells they have early on, and how do they change to become myeloma, what kind of immune cells you have, and how do they alter your progression to myeloma, and can we develop better imaging and better therapy for you. Imaging meaning, like, instead of a PET CT scan or an MRI, we want to develop something better for you. So how are we doing that? We're doing it on the ground, and this is especially before COVID, and now we're back in business post-COVID. So we're going to health fairs, we're going to church events, we're talking to our Congress men and women, and we're trying to really talk to everyone. And we would encourage you, this is truly a community effort, and we want everyone to be part of it. So if you're interested to help us, if you're interested to spread the word, please do. These are some of our numbers. So far, we've screened 2,592 people. Of those in the US, 6,400. And we've worked also with South Africa, which I'll talk to. Now our numbers in general are about 10,000, and we have screened positive 1,000 patients. Here are some of those numbers. As you can see here, we have PROMISE South Africa. We also have a collaboration with our MGB Biobank here, the Brigham and Mass General bank that we have, and we are recruiting from it. Of those, we have the largest number of Black Americans, 3,866 who have been screened to date, and 8,653 with family history. And these are just showing you some of those numbers early on from the first 7,600. So what did we find? First of all, we did not screen by just the regular serum protein electrophoresis, that M-Spike, because that's a 50-year-old technology. That's an older technology. We wanted to screen with a much more sensitive and accurate test, which is by mass spectrometry, something called the binding site MALDI-TOF. And what we found, which was very interesting, is what I call the Christmas tree. So if you were just by serum protein electrophoresis, you would be this dark blue, and we would find some of the patients. If we do immunofixation, we would find the light blue. What we found is mass spectrometry can find both dark and light blue very accurately, and even better than SPEP. But more interestingly, we found a very lower level of monoclonal protein, even lower than what we can detect now. And we wanted to term this something other than MGUS, so we called it MGIP, monoclonal gammopathy of indeterminate potential. And what we want to say here is those are small monoclonal proteins that are even before you can detect them by serum protein electrophoresis, and they were very common in the general population. So that actually surprised us to find that many proteins in many of us walking around. So here are the numbers. As we get older, many of us will develop MGUS. By age 50, if you were just looking at the general population and you were just using SPEP, it would have been the 3%. You double that number if you're screening in PROMISE, because you are at risk, and that's only by serum protein electrophoresis. You increase that number to 13% because mass spectrometry is much more sensitive if you do it by mass spectrometry in the same population. And then there is another 20% of people who have this MGIP that now we're starting to know what it means and what does it signify. Now, in general, everyone who had MGUS or even MGIP had a slightly worse overall survival, meaning we're probably dying from other things, heart attacks, blood clots, autoimmune diseases. Something else is causing some of our death, not just multiple myeloma. And interestingly, and before I go to that, what we're doing right now is we're also looking at those early monoclonal gammopathies, those MGIP, and we're finding that some of them are LL or early lymphoma. So potentially we could be screening not just for myeloma, but also for CLL and lymphoma. Now, the next step is something called risk stratification, meaning I have MGUS, I have smoldering myeloma. What is my personal chance or my personal risk of developing myeloma? And we call this the hurricane model because we're trying to predict the hurricane. So in the Weather Channel, if you're watching someone and they say, well, the hurricane will hit the northeast area in the next 3 weeks, that's not very accurate. You want accuracy, you want precision. You want someone to tell you it will hit Boston area, which is unlikely, but let's say it will. It will hit the Boston area Thursday afternoon. Now you can plan for things a little bit more accurately. So this is what we're doing. We started sequencing many of the cancer cells, even as early as MGUS and smoldering myeloma. And we started looking at that prediction of where the hurricane is going. And we found indeed, showing you here a couple of samples from one patient who had smoldering myeloma and then go on to develop myeloma 5 years later, that some of those clones, remember your cancer cells are not the same, all of them. Some of them have specific changes or clonal mutations, and some of those will grow more than others. So by doing sequencing, what we call NGS, next generation sequencing, I can be more precise in my prediction whether you will go on to develop myeloma or not. So if you have a KRAS or an NRAS, which are specific mutations in your DNA, those can be predictive of you progressing to myeloma. Now we took it one next step further. We said, well, can I do it in the blood? Because bone marrow biopsies are not fun and no one wants to do them. So we started actually pulling blood samples and taking the small numbers of cells that circulate in your blood. Even at MGUS, you have a small number of cells circulating, and we can pull those out and do this next generation sequencing. And what we found is that it was accurate in predicting everything that happens in the bone marrow. In the future, we may not need the bone marrow biopsy, and it was much better than the traditional FISH that we do for you right now clinically. In fact, we're hoping to replace FISH very soon, so that when you come to Dana-Farber, instead of ordering a bone marrow biopsy and FISH, we would order this new MinimumSeq method that we have developed. And hopefully that will give you more information, and it will be from a blood sample. Now, the next step we wanted to look at is what else is going on in your body other than the cancer cells, and can I look at them at the single cell level, meaning every single cell, can I look at it? And this is showing you why single cell sequencing matters. So if I look at all of your cancer cells and mush them together and give you a picture of all of your cells together, it looks like basically a smoothie. Tastes good, but you can't tell which fruit was which. If I look at single cell sequencing, it's basically like fruits. I can tell you a raspberry from a strawberry, a bad cell from a good cell, a mutant raspberry, a bad raspberry from a good one. And that single cell level can really help us. And hopefully soon we're going to do something called spatial transcriptomics, where we can actually look at your cells in the bone marrow. Where do they like to sit? Do your immune cells like to sit by the cancer cells and kill them, or are they far away? And that can help us understand how to develop therapy in the future. So we took samples from MGUS and smoldering myeloma, as well as healthy controls. And what we found is when you are healthy, which is yellow, we may be able to compare a patient to a healthy person. But here, because we have some normal cells, because we're doing single cell sequencing, we have some normal cells and some bad cells, which are purple. We can differentiate normal from bad cells. And that's critical because now we can develop therapy like CAR T, like bispecific, like vaccines that only kill your bad cancer cells and not kill your good normal cells. So that's the beauty of single cell sequencing. And that's just showing you normal cells versus cancer cells within one patient. I can differentiate them from each other, the plasma cells themselves. So we took that to the next level, and we did 245 samples that we are analyzing right now from MGUS, from smoldering myeloma, from myeloma. Many of those patients were on our pCrowd study. So everyone on pCrowd, thank you for being part of it. And hopefully that shows you how much data you give us in understanding better your disease. And not only we found that, but we can actually differentiate different subtypes of tumor cells. So if you have a 1416, if you have a 1420 translocation, we can actually see the proteins on the surface, and now we can develop therapy specifically for a 414 or 1416 or 1420 because of that single cell level that we have now. Now, your cancer cells don't live alone in the bone marrow. They are surrounded by other cells, immune cells. And immune cells are so critical because they can be killers of the cancer cells, as we know now from all of the immunotherapy that we have now. So we started looking at immune single cell sequencing, trying to understand how your immune system looks like when you have MGUS or smoldering or myeloma before therapy, after therapy. Can I use it to predict that you will respond well to treatment or not? And what we found, which was very interesting, that even at the MGUS stage, your immune cells are not completely normal. You already have many of the changes that happen in myeloma, but they get worse and worse as we get to myeloma. So here you can see that the cells that like to fight your cancer cells, some of those effector T cells or memory cytotoxic T cells, we keep losing them as we go on from MGUS to myeloma. And that's critical because we want to develop better immunotherapy. So we should be developing it and treating people who have MGUS and smoldering myeloma before they progress to active myeloma if we want to harness your immune system. And then the other thing we said is, let's try to understand if I take samples before you go on treatment, and I take samples after you go on therapy when you are in MRD, when you're in your best response, can I predict if you will respond to therapy? Again, we usually look only at the cancer cells. Let's also look at your immune cells. Let's look at that half of the coin that we've been ignoring for many years, and will it be predictive for your future of prognosis of response to therapy? So we looked at 190 samples from many people, from their bone marrow, from their blood, to see if we can actually use blood instead of bone marrow biopsies. And what we found, which was very interesting, is your immune system is reacting to the bad cancer cells, and that reaction can actually be prognostic. It can tell us that you will respond well to therapy. This could be very useful because I can take a blood sample, I can look at your immune system, and I can say, potentially, am I going to respond to CAR T? Am I going to respond to bispecific, or even to their RVD, or to transplant? Even post-therapy, when you're in MRD, post-transplant, post-therapy, when I'm in my best response, is my immune system also in its best response, what we call immune MRD or immune normalization? And will that be predictive for long-term outcome for me? So big questions here. What can we understand about, as we get older, our immune system, and how is it different from someone who has MGUS, and why would they progress or not progress? And how can I use that to develop therapy? We're trying to develop actually vaccines now based on this data for not only our patients with MGUS, but also when you are in best response to prevent progression. So this is just showing you lots of those immune cell sequencing, really differentiating who will progress and who will not from healthy or MGUS or smoldering myeloma, and also showing you that your T cells, which are the killers of your cancer cells, they lose a little bit of their activity or their ability to attack your cancer cells as we go on to develop myeloma. So lots and lots of data that indicates, let's treat early, let's prevent it early before it goes on to myeloma. So how do we do that? As you know, in smoldering myeloma, there has been 2 clinical trials done before, 10 years ago, that show that indeed, if I treat you early, you have benefit. Something called lenalidomide and dexamethasone, Revlimid and Dex. Many of you who are treated have received Revlimid. But the question is, should we really treat all smoldering myeloma the same way? And should we really give them Revlimid and Dex? So we want to be precise. Smoldering myeloma that's very mild can receive RevDex. Smoldering myeloma that has bad mutations and bad disease or bad immune system potentially can receive something stronger or something different. So we're developing multiple precision interception. We're also looking at your own translocations. If you have 1114, let's give you something venetoclax. If you have an immune system dysregulated, let's think as in immunotherapy in those patients. So this is a huge portfolio we have. Even in MGUS, we're doing simple things like intermittent fasting, metformin, obesity drugs, many things that we think, instead of working on fat cells, they may actually change your metabolic pathways and actually prevent progression from MGUS to myeloma. And in fact, we're testing in many people the microbiome, meaning your own bacteria in your gut, because it can affect your own immune system and change the way you respond to therapy, including CAR T and immunotherapy. And then when you progress to a higher stage, whether it's high-risk MGUS or smoldering myeloma or high-risk smoldering myeloma, we are developing bispecific antibodies like teclistamab early on. Let's bring it earlier because that's when you can respond best to those immunotherapies. CAR T, we're going to open a CAR T trial in smoldering myeloma because we know that that's the best time to really harness your immune system to use your own T cells against themselves or against the cancer cells. So this is one of the studies. It's open right now. Teclistamab and talquetamab will be opening soon, but teclistamab is open right now, where we are treating patients as early as smoldering myeloma with the best drugs that we have for fifth or sixth line of therapy. We're saying, let's bring it as early as possible and treat you early. And same for CAR T therapy. We hope to open it soon for our patients. So I hope I took you through many things that we do, both in the lab and the clinic. The beauty here at Dana-Farber is we do both. We see you and we take your sample and we go to the lab across the street and we study it. And then we come back and tell you, here's what I found. Here's why it can matter for you. And we go back and forth until hopefully we will cure multiple myeloma. But I personally think we will cure myeloma by treating it earlier, by diagnosing it early because we can, by treating it earlier because there's nothing good about having fractures and lesions and anemia and renal failure, and by potentially predicting better who would respond to which therapy, precision interception in our patients. So with that, I want to thank you so much, and thank you for having me talk with you all.